Hello, my name is Diane Burns, and I'm the Program Manager here at the Spina Bifida Coalition of Cincinnati. We're here for our fourth webinar in the Create Your Future series, Understanding Orthopedic Options. Jeremy Moses joins me here in the office as co-facilitator and technical consultant.
Hello, everyone.
I would now like to introduce our presenter, Dr. Ashley Bolger. Dr. Bolger is Associate Program Director in the Physical Medicine and Rehabilitation Pediatrics Combined Residency Program at Cincinnati Children's Hospital Medical Center. She specializes in spina bifida, cerebral palsy, traumatic brain injury, and other neuromuscular disorders. The focus of her research is on transition of care from pediatric to adult health care, an ongoing challenge in spina bifida and other developmental disabilities. Dr. Bolger received her Bachelor of Science from Truman State University in Missouri in 2005 and her MD from the University of Missouri-Columbia in 2009. Welcome, Dr. Bolger.
Hi, everyone. Thanks for having me for this webinar. I really appreciate this opportunity. Today, we're going to kind of do a whirlwind tour of a couple different things related to physical medicine and rehabilitation in the spina bifida population. So in terms of objectives, there's going to be three main ones. We're going to talk first about bracing options that promote independence in children with spina bifida. Then we'll talk a little bit about mobility equipment that's utilized by those with spina bifida and understand some of the options for customization. And then lastly, and kind of more interspersed throughout the presentation, we're going to review some current insurance limitations for both bracing and mobility equipment that are pertinent for both families and individuals with spina bifida that have these needs. So to get started, our first general topic is going to be bracing in children, adolescents, and adults with spina bifida. So Jeremy, if you could launch the first poll question, that would be great.
There we go. And we'll give you a few seconds to answer that question. And well, there we go. We're already at 100%, so we'll go ahead and close it. And looks like the majority is AFO. So, Dr.
Okay.
Bolger?
Okay, so great. I just wanted to get a sense of kind of what folks were wearing out there in terms of their bracing options to get a sense of what we're talking about. Just so that you do know, I will kind of go through the bracing options, and at the end I'll leave some time for questions specifically regarding bracing. But when you're looking at bracing options for those with spina bifida, there's lots of different options out there. This is kind of a list of the different general things that I may or may not recommend for those with spina bifida. These are often dependent on the level of the lesion, as well as kind of foot positioning and just the general pattern of their gait. And so I like to think of things in terms from least supportive to most supportive, and that's how things are listed on this slide. So looking at the least supportive option, there's something that's called supramalleolar orthotics, or SMOs, you might hear them referred to. Moving up the chain, we'll talk about each of these individually in a moment. You have ankle-foot orthotics, or AFOs. Those can be further divided. Typically, the two most common ones that we use in kids with spina bifida are either the solid ankle AFOs or the ground reaction AFOs or the GRAFOs. Next up is the knee ankle foot orthotics, or the CAFOs, and then lastly is the hip knee ankle foot orthotics, or the HKAFOs. If you haven't figured it out yet, the way that AFOs or bracing options are named is by the joints that they cross. So if you have an ankle foot orthotic, you're going to be bracing your ankle and your foot. Same thing goes with your knee ankle foot orthotic. Those are going to cross those joints. And so that's a quick and dirty way to remember what type of brace it is. So starting from the least supportive, or the supramalleolar orthotics, or the SMOs, these braces are truly just meant for those individuals who have some weakness both in their foot intrinsics as well as maybe a little bit of weakness in terms of rolling at the ankle. They're not meant for any individuals that have the inability or the difficulty in lifting their foot up or pointing their foot down, but they're truly just meant to correct that tendency for the ankles to roll. As you can see, they're not very tall, so that's a good thing and a bad thing. Great thing in terms of being a little lighter weight, a little better tolerated, but for those kids that may need a little bit support they're probably not going to provide that support that we need. And so I would say usually the kids that are needing supramalleolar orthotics are usually those kids that are more at the sacral level of lesions. And usually if you get a little bit any higher than that, you're looking at something a little bit taller and a little bit higher. So that's the supramalleolar orthotics. Let's go back on that. So then we go up a little bit higher to the ankle foot orthotics, or the AFOs. Like I alluded to earlier, the two main types that we prescribe in kids with spina bifida are the solid ankle type, which are the pictures on the left, and then the ground reactive type, or the graphos, which are the ones on the right. So thinking a little bit about the solid ankle AFOs, in general, these tend to be the first braces that I prescribe for the younger kids. And the reason being is that younger kids really need stability in order to learn things like walking, pulling to stand, and doing all of those kind of first-time developmental milestones. They don't do as well when you add things like hinges or give them a little more mobility at the ankle. And so that's why we choose the solid ankle AFO design. All of these AFOs, I would recommend that they're custom molded to the individual's foot, whether that be a 2-year-old that's getting his or her first set of braces up into an adult who's had braces all their life. I would always recommend that these are custom molded. And a lot of that has to do, well, with two things in particular. Is kids and adults with spina bifida, obviously don't have the same sensation on their feet and their ankles as do a typical kid. And so a more custom brace is just going to be able to better accommodate that and be a little bit better fit than an off-the-shelf brace, especially in those who don't have sensation at the same level as a typical individual. And then the second reason I always recommend custom braces for people with spina bifida is that, there's usually just a ton of different foot abnormalities that go along with spina bifida. Club feet are one of them, but even in kids that don't have club feet, a lot of times their feet just aren't as flexible, and they have some differences from a typical foot. And so creating custom braces really accommodates and allows for accommodation for those differences. So typically for solid ankle AFOs in the younger kids, I'm usually recommending them when they start pulling to stand. If an infant or a toddler even isn't starting to pull to stand and their foot position is overall good, all a solid ankle does is make the kiddo angry and doesn't allow them to do the things they're trying to do in terms of exploring their environment. So I'm usually waiting a little bit until either A, they're trying to pull the stand again, or B, I'm concerned about their foot position or really want that foot position to stay stable. So then as kids get a little bit older, we look at things like ground reactive AFOs, or the graphos. Now, these are great for kind of that mid-lumbar level, maybe a little bit lower, that low lumbar level. And the true reason that graphos are successful is that they help kids that have a little bit more of a crouched gait pattern. And so a lot of kids in that mid-lumbar to low lumbar level are walking with a crouched gait pattern. And if you think about it, basically the reason behind how these help with that crouched gait is you see kind of that anterior shin plate on the picture, and that's basically serving as a force pushing backward and getting their knee a little bit straighter is the way to think of it. And so typically these are a little bit harder to make. That's why we don't use them for the first set of braces, just because of the shape of a toddler's foot and ankle. They just don't do well in trying to mold them to fit a ground reaction AFO. And so typically somewhere around the age of 2 to 3 is usually when I'm looking at, would a kid benefit from a ground reactive AFO? Do I think they're old enough? And then I'll have that conversation. If a kid isn't crouching very much, then they may be fine in a solid ankle AFO or even something lower. But if they really have even a moderate amount of crouch, I'm usually thinking and leaning towards switching to that ground reaction AFO. So those are the main types of solid ankle AFOs. There's also other options that have hinges, and you can modify AFOs in general to have various different things on them. So another option that we've been starting to recommend, kind of a meld of the first two options. So it's something called a carbon fiber AFO, or the black brace on the right, and then you pair that with that supramalleolar orthotic. And so the combination of these two braces, they use and they they function like a ground reaction AFO. So they cause that knee to go into a little bit of extension, and they decrease the amount of crouching that a kid is having all the time while keeping that ankle in a good position and not allowing that ankle to roll either in or out. And so the benefits to using this as opposed to a traditional ground reaction AFO is that they are a lot lighter weight than that brace, and they are significantly easier for an individual to put on or to take on and take off. And so that's certainly something I think about, especially in my older kids, both of those combination of things where kids are wanting to be a little bit more active and they're wanting that independence. I'm starting to look towards these braces. They also, one of the big added benefits in the right kid is allowing a little bit of movement at the ankle. So in a true ground reaction AFO, there isn't any movement that's allowed at the ankle in terms of pulling your toe up or pushing your toe down, which makes stair climbing a little bit difficult because your ankle's fixed in that locked position, and so you're not able to get that little bit of movement that makes climbing stairs easier. And this combination of braces actually allows for a little bit of that type of movement. And so people some of my teenagers and young adults who are now wearing these, really one of their biggest pluses for them is that stairs are a little bit easier if there's someone that is able to climb stairs. So this is just one more option that's out there that kind of melds those first two together. And then I alluded to earlier, there's lots of things that you can add on to your AFOs or your ground reaction AFOs. One of the things that you often see is twister cables and or twister straps. So twister cables are the traditional ones that have been around for many, many years. That's the top picture with kind of the waist band. And they're intended to be for kids who are either in-toeing, or the common term for that is pigeon-toed, or out-toeing or duck feet. They work better if both feet are pointing in the same direction, so either both toes are pointing in or both toes are pointing out. They don't do as well for, both toes are pointing to the right or both toes are pointing to the left. If a kid is less than 2 years, it's very, very difficult to get the componentry of the twister cables to be small enough. And they also are a little bit bulky, and kids that are younger than 2 just don't have a real easy time with that. So I'll often use the derotational straps or the twister straps for those younger than 2. And then once they get to the age of 2 or 3, if they're still having those issues, twister cables are usually a little bit better option. They're a little bit more sturdier. They give you a little bit more pull. And so we switch to those. The biggest debate in the world of twister cables and straps is, are these going to fix my rotational deformity permanently? If you look at the literature, there's no literature out there to support that if you wear these and then you take them off, that your correction will be maintained. However, those of us who have been taking care of kids with spina bifida, myself and some of my partners, have definitely seen a handful of kids that if they wear their twister cables or their twister straps religiously, they seem to have improvement as they get older, and then they end up coming out of the twister cables. Some kids will just wear them when they're younger. Some kids will wear them into adolescence and adulthood. It's really kid dependent. I think a lot of the kids I'm seeing as they get older and maybe choose to either walk a little bit less or use wheelchairs a little bit more, they end up ditching the twister cables and straps just because they're hard to put on, they weigh a little bit more, and they truly, especially in those kids that aren't seeing a correction once they take off the braces, they're really not seeing the benefit of that. So those are basically twister cables and straps, and are another thing that you can add on to braces. So then we move up a little bit on the support to the knee, ankle, foot orthotics. So like I said earlier, these are bracing not only the ankle and the foot, but also now taking into account what the knee is doing. As you can see in these pictures, these braces are a lot more involved. They're giving really good support at the knee, and they brace up to about the mid-thigh. In terms of when I would think about using a brace such as this for a kid, these are probably mostly going to be more in your upper lumbar, sometimes occasionally mid-lumbar individuals, and for 2 reasons. One, if they need the support in terms of stability, if their knee muscles around their knee are weak and they're not able to bend or straighten them as I would hope, then these braces will often provide that little bit of extra support. And then the other big option is if kids are knock-kneed typically, and they're putting a lot of stress on both sides of their knees. I often will recommend these just to protect their knees, especially if they're a really active individual and walking a lot. I want to make sure that their knees are healthy and maintained and not going to have pain when they reach young adulthood. And so I'll often look at something like a KAFO to keep those knees aligned a little bit better and not so much stress with activity on them. Like you can see in the picture, they're big, they're bulky. A lot of individuals who start off in KAFOs that actually need KAFOs end up, as they get older, typically ditching the KAFOs and using more in terms of wheelchair mobility. For those that are using them just as support, sometimes they'll end up just saying, you know what, I don't want the knee component. I'm willing to kind of give up that stability a little bit. I still need the braces. I still want to walk, but they're going to go more towards a traditional ground reactive or AFO style. But I think they're just big and bulky. They're hard to get on. And I think, you know, overall, I think people don't end up using them most of the time into adulthood because of those two things. So then lastly, and probably the bulkiest of the braces that we often recommend, are the hip, knee, ankle, foot orthotics, or the HKAFOs. There's a couple different versions of this type of brace. One of kind of the subsets is something called a reciprocal gait orthotic. These are really for those thoracic or really high lumbar kids that have a little bit of hip movement, but not much more than that. And so a lot of these braces are really providing kids with the ability to stand more than anything, maybe take a few steps here and there, but they're really not meant to be something that are helping kids to walk in the community, to walk long term. They're really trying to get them up, get them weight bearing, and provide their bones a little bit of, you know, gravity to develop through. As you can see, they are extremely bulky. They all have some sort of chest brace attached to them. That's how they work. That's how they provide enough support for the kids who need it. And like I said, they're usually mostly being used for kind of those standing activities and to give kids a little bit more upright activity. But 9 times out of 10, people aren't using these into adolescence or adulthood. So it wouldn't be a great presentation if I didn't talk about why I feel like braces are so important, because I truly think this is one of the biggest things that I do, both in kids, adolescents, and young adults, especially in the spina bifida population. So I think of bracing for, you know, in 2 ways. That it not only improves function, but my other big thing, and probably more important as you get older, is that it maintains your foot position and prevents deformities. So when we're thinking about improving function, I'm looking at how do I aid or replace the muscle groups that are weak. So in kids with spina bifida, how do I help them be stable at their ankle when their muscles that are controlling the ankle don't work like they should? And that's going to dictate which type of brace I recommend. And that's really the reason that most kids are going to want to wear braces. They're going to want to run with their friends. They're going to want to walk with their friends. They're going to want to do things that all the other kids are doing. And that's why they want to wear braces. Now, another main reason that I'm wanting to keep braces on through adolescence and adulthood, when sometimes young adults are not wanting to wear them, is that braces are going to help maintain your foot position. We know that in kids that have weakness at their ankle and their feet, if they walk on their feet in a different way, they're either flat-footed or they're rolling out, and they walk on those long term, they tend to end up developing contractures and aren't able to get their foot in a good position. Long term, that causes difficulties with shoe wear. It causes difficulties with stability in terms of falling. And ultimately, it often leads to a lot of pain. And so in the back of my mind, even though I always want to improve function, I really have an inner goal to maintain a child's foot position and to prevent deformities in the end. And ultimately, the goal of this is really to decrease the risk of the need for surgery. It's at some point you get to a point where if a foot isn't braceable, and it's just progressing more and more, I as a physiatrist can't do a whole lot else to help that foot or that individual. And then it's that time when I'm starting to talk about referring them to an orthopedic surgeon to look at options for that. And I truly want to avoid that at all costs, as does our orthopedic surgeon who I work with. So just some highlights about bracing. Like I talked about, they should always be custom molded. So typically that means you're working with an orthotist, sometimes a physical therapist, taking a mold of a cast. You usually apply just like you would when you break your foot. You apply a cast, they cut that off. They end up either creating a mold in the office of that, or they end up sending it to a company to create a mold. But that's the basic background behind those custom molded braces. I always recommend wearing them the vast majority of the time when the individual is ambulating, and again, that's to protect that foot positioning. It's certainly going to hopefully help their function, but in the end, I want to make sure that their ankle and their foot is in a good position so that they're maintaining that joint integrity as they get older. And so my typical response, if people ask me how long I want them to be wearing braces, I say they should be out of their braces no more than an hour a day. Now that doesn't take into account if you're laying on the couch watching TV, it is absolutely fine to be out of your braces. But when you're ambulating, it should really be limited to less than an hour a day of ambulating. So I always tell them, you know, when you're getting up out of bed and going to the bathroom, that's a fine time. You don't necessarily have to be in your braces in terms of foot protection. But if you're doing much more distance than that, you really should be putting your braces on and walking in your braces. I always recommend if there's any red spots that are developing, that's a sign that your brace isn't fitting correctly, and so you should see your orthotist or your therapist, whoever you work with for your braces, immediately before you keep wearing those. Don't put that off. I've seen all too many times where people get busy, and that's totally understandable, but then all of a sudden we have a big skin ulcer that's really hard to correct, and now we're out of braces for months at a time. The other common pitfall I see with some folks that make braces in the spina bifida position is the length of the toe plate. So that bottom part of your brace, they often make it really long in kids. And for most kids, that's okay because you want to try to accommodate up to a year's worth of foot growth for that pair of braces. But what we know in kids with spina bifida, their feet don't grow as fast as the typical child. And so you don't have to leave a whole lot of room on that toe plate because chances are their foot isn't going to grow as fast as they will before they outgrow the brace for other reasons. And so I'm often looking at braces in clinic and recommending that folks go back to the orthotist and have that toe plate shortened so that they're not tripping on it. The other caveat to bracing is insurance approval. So just so everyone out there knows, the average insurance company, whether it's Medicaid or private practice, will in children pay for a pair of braces about every year. Now with that being said, many policies are not written with children in mind, and so the policy is actually written for adults. And they actually say that they will replace orthotics every 3 years, or sometimes I've seen even some policies that say every 5. And while that's okay in adults, obviously a 1-year-old child who's getting their first set of braces is not going to fit in the same pair of braces as when they're 4. And so if insurance companies are denying it because it's, you know, written in the policy as 3 years, that's often pretty easy to argue, and you should just let your physiatrist or your physician managing your braces know about that. Things that are also helpful, so those of you that probably go through braces know this, but your orthotist is typically the person that makes and orders the braces. They'll send an order form that delineates the type of brace and the specifics on the brace to your physician. The physician will sign off on that, and then it goes to insurance to submit that. I will say it's pretty helpful if you have a rehab physician helping to manage those things, and that's mostly, I feel like, because when those insurance questions arise, a rehab physician has that background knowledge to be able to fight your cause and to argue why you need that custom set of braces and why, more importantly, you need that specific brace that was recommended. One of the newer things that I'm seeing probably over the last 2 or 3 months actually is a new we'll say rule that some insurance companies are implementing, that the individual who's getting a new pair of braces needs to be seen by the physician who ordered the braces within the last 3 to 6 months. I've seen some as short as 3 months, some are saying 6. I would say as of right now, it's not consistent. It is very insurance dependent on whether you can do that. And I think the biggest issue that this brings to light is a lot of times by the time you're in your school-aged years or 10, 11, 12, 13, you're not being seen in spina bifida clinic or by your rehab physician more than every year if you're stable and there's nothing going on. And so you're not necessarily outgrowing your braces right at the time that you are seen in spina bifida clinic. So I think this is going to be determined about how we're going to navigate this process. But just know that there are some insurance companies that are adopting the need to see the physician within the last 3 to 6 months. So with that kind of ends the section on bracing. Is there anybody out there that has any questions related to bracing, anything that you wanted to ask? I'd be more than happy to answer questions at this point. Take a brief moment, pause.
You've actually covered everything really well, so at this point, we don't have anything coming in. As always,
okay.
I do want to encourage people to, if you came in late, if you missed part of this, the recording, we'll let you know later on how to get the recording of this webinar down the road. But and as always, you can continue to submit questions through the questions pane in your control panel. So, Doctor, go ahead and keep on moving.
Perfect. Okay. With that, we're going to keep rolling right through this. So the next big chunk that we're going to talk about for the remainder of the presentation is mobility equipment. So Jeremy, if you could put up poll question number 2, just so I get a sense of who's out there and what folks are doing, that would be great.
Yeah, we'll do that right now. The question is, are you or your child a wheelchair user? And the options are yes, part-time / long distances, yes, full-time, or no. So go ahead and vote now, and we will close it in a few seconds. And with that, wow, we've already got 100%, so we'll go ahead and close it now. And the majority, in fact, 100% of the response is part-time, long distances.
Part-time. Okay, perfect. And that's pretty typical for the vast majority of the patients that I see in clinic, that kids, young adults, and adults are using their wheelchairs more on that community distance ambulation, things like going to the zoo, going to the mall, going to work, but really aren't using a lot of wheelchair mobility within the house. So that's kind of what I expected. So with that being said, we're going to kind of do a broad overview of the types of different mobility equipment, and then I'll go through a little bit more in depth on each of these. So again, I always like to think of things in terms of least to most intense, except there's a little bit of things at the end that I just kind of threw in the end. But in general, people with a lower level spina bifida lesion, so those low lumbar, sometimes sacral lesions, typically the only thing they're going to need in addition to braces, if they need anything at all, are going to be things like crutches or walkers. Occasionally, somebody with a upper lumbar lesion will use something called a gait trainer. And then you get into more of your wheelchair options. So the 2 main categories of wheelchair options are your manual wheelchairs and your power wheelchairs. And then kind of the extra stuff, or so to speak, are the mobile standers, and then the zip-zac or the scoot, or I'll call them baby mobility devices for the purposes of this. So moving right along, the first thing we'll talk about is Loft-Strand crutches. So that's the specific name for these particular type of crutches that have the arm cuff and then the handle on them. They're called Loft-Strand crutches. Most of the time, these are typically being used by kids with upper to mid lumbar lesions. They're typically used in combination with AFOs or some sort of bracing. Sometimes these are kids that are using the KAFOs or even occasionally the HKAFOs for support. They're typically not used until kids are in that sort of preschool to early school-aged age range. And that's really just because kids that are a little bit younger than that typically don't have the coordination to perform or to use Loft-Strand crutches. And so typically when kids start becoming usually the age of 5, I'll start thinking about it. If they're still working with walkers or doing things like that, we'll start having discussions about whether they would maybe benefit from a trial of Loft-Strand crutches. But they're a really good option for those kids who really just need a little bit extra support for balance and can't quite do things with just their braces. And many adults walk with Loft-Strand crutches and use these long term. I've even had some young adults and adults use these for more of their community distance. So they'll walk in the house without their Loft-Strands, but once they go out in the community or walking around the mall, they just feel a little bit more stable and have a little bit more energy if they use their crutches. So the other option that provides a little bit more stability are the category known as walkers. There are tons and tons and tons of different brands and types of walkers out there. These are just 2. I feel like these are 2 fairly common ones that we recommend, but they are by no means all-encompassing. So they're the 2 that I put a picture up here are the K-Walker and the Nimbo Walker. As you can see, they look fairly similar. Most of the time what we're recommending are things called reverse walkers. So I don't have a picture of a kid in a walker here, but what you think about is that bar that you see on the walkers, that actually goes behind the child or near their rear end. And the reason for this is that in kids with spina bifida, they tend to lean forward in general just because of their pattern of weakness. And so using a reverse walker really keeps them more upright and doesn't allow them to kind of push that walker and create more of a leaning forward gait pattern. And so that's why I typically default to the reverse walker. There's the every once in a while occasional kid that just really refuses to use their walker in a reverse fashion, and then we'll just flip it around, and you can use most of these walkers as a forward walker as well. But I would say nine times out of 10, I'm recommending them be used as a reverse walker. A lot of times kids will use these as they go through the developmental milestones. So kids may use them when they first begin walking. Some kids may need to use a walker to achieve mobility and through adolescence. Other kids may get rid of them as they start taking some independent steps. They're able to coordinate those movements. They're able to gain the balance needed to do that. Some kids will go from this into Lofstrian crutches. Some kids will just ditch the walker and go straight into walking. It's pretty variable and it's pretty individualized. And so these are things that your physician can certainly write an order for. Typically, I recommend working with a therapist to get fit for the appropriate one and to also to trial them. While there's tons of different types of walkers, some kids prefer one type of walker as opposed to another. And so I always recommend that if you're going to purchase a walker and you're going to use insurance money to get a walker, that your child or you have tried that walker before you purchase it. Because once you purchase it, once you use insurance money at least, they won't pay for another walker until you can prove that you've outgrown it or there's another reason why you need a different one. So a little bit more supportive, but in the same realm of the walker is the gait trainer. These are, in spina bifida, I don't use these nearly as much as I do some of the other things, but they're still certainly an option. So as you can see, the gait trainer basically blends a more supportive walker with a harness. So you're getting a little bit more support through your trunk as well as your hip area. And so these are I'm typically using these in kids with the upper lumbar level lesions, so kind of that L1, L2 level. Again, these are kids that are going to need a little bit more support to walk, and this gives them a way to do that more independently. I think about these for those of you who were with us earlier in the braces. I think of these for kind of the same kids that might benefit from an HKAFO. That's a gait trainer sort of serving a similar purpose. They're able to walk short distances. They're able to do so a little bit more independently. They're able to get up on their feet and to have some weight bearing through their legs. But these are bulky. They're transportable, but not horribly, easy to transport. And so I'm usually thinking about these in terms of short distances around the house, giving them a form of mobility, but I'm not thinking about these in terms of a kid's primary form of community ambulation long term. Again, there are, just like the walkers, there are tons of different brands, tons of different styles of gait trainers. And my biggest recommendation is if you're looking at a gait trainer, you want to make sure you try out that specific gait trainer before you submit through insurance. Insurance will pay, most insurance plans, I should say, will pay for walkers and gait trainers. But again, there's limits in terms of when they're able to replace those. And so if you get one of those pieces of equipment and it doesn't work for the child, usually you're pretty limited in terms of what else you can get in that realm for about 5 years after that. So then moving a little bit into what I call baby mobility are the Zip-Zacs and the Scoots. Now these, I really love these devices. I will say they are kind of on the commercial market. These are not medical devices. They don't have medical codes that you can submit through insurance and get them paid for through insurance, but they really are kind of awesome for the kids that are needing them. So I'm typically talking or introducing Zip-Zacs and Scoots for kids under 2. Typically, by the time you get 2, you start outgrowing them for the most part. But these are great forms of mobility that provide that kind of floor mobility, that provide that kind of getting around the house at an age-appropriate level. So the times when a kid would be crawling, when a kid would be an early walker, they're not meant to be, going out in the community, using them at malls, going long distances, but they're very age appropriate for those kids that are having their early forms of mobility. So the one on the left is the first thing that came out. It's called the Zip-Zac. Again, I think they're both pretty similar in what they accomplish. The things I will say about the Zip-Zac in general that I've seen, you just have to be really careful if you're using it with your kids for long periods of time. The seat bottom is not cushioned, and for a lot of the kids that are needing and wanting to use this type of device, they don't have the best feeling on their bottom, and so I've seen some skin concerns for kids that are using these for hours and hours at a time, just in terms of getting their bottoms red, or even honestly creating some pressure ulcers at times. The next thing that came out was the Scoot. It's made by a company called Firefly, and it actually is a 3-in-1 mobility device, is what they kind of promote it as. So as you can see in the picture, it not only, as the bottom picture depicts, serves a similar purpose as the Zip-Zac in terms of being able to push the wheels and get around from a floor mobility standpoint, but it also provides options for tummy time as well as supported sitting. Both of these options are typically, you can find them in the realm of $500 to $700. The Scoot is typically just a smidge cheaper than the Zip-Zac, but again, unfortunately, insurance doesn't have codes for these, and so you're really looking at alternative funding sources when you're looking at purchasing one of these for your child. So that's the Zip-Zac and the Scoot. Then looking at the options for wheelchairs, like I alluded to earlier, the two categories that wheelchairs fall into are the manual wheelchairs and the power wheelchairs. When you're looking at manual wheelchairs, you can go with a traditional fully manual wheelchair where there's absolutely no power options, or there's some really awesome things that have come out in the last 10 years that give you the opportunity to switch between a manual wheelchair mode and a power mode, or a little bit of a boost mode is how I usually describe it to families. And so the manual wheelchairs are just basically the options that you see up there. Usually they're fairly lightweight. Typically for an adult-sized frame, usually 30 pounds or less is the total weight for those ultra lightweight and lightweight wheelchairs. There's varying different ways that you can customize them. There's different size frames, there's different seat cushions, there's different types of backs and heights of backs. Nearly every option is customizable, or at least you can choose which options you want that fit the individual needs. And so this is great for not only, people that need wheelchairs as their primary form of mobility, but also those that need wheelchairs for those community distances. So then you can also add on something called power assist options to your manual wheelchair. The two most common ones that we're recommending at the current time, first one's called the Smart Drive, the second one's called eMotion Wheels. The eMotion Wheels, I believe, were the first ones to come out. They're a little bit older. They've gone through multiple revisions since they first came out, but they are truly wheels that you pop on and off the chair. So they have a power pack in the center, as you can see that bottom right picture. The downfalls of them, they are very heavy to put on and off. So for people that are wanting to drive, wanting to be able to independently get in and out of their cars, eMotion Wheels, that's the biggest complaint I get for them, is it's really hard for somebody to get them in and out of a car if they themselves are doing it. The driving, the power assist options, what they're providing are great. Most people love that part of them. It's really just the need for the additional weight and how it's broken down for transport is typically my biggest complaint. The other option that came out a little bit later and actually just went through a really recent revision in the last, I think it's been out for a couple months, the newest version of it, is called the Smart Drive. So the Smart Drive is actually the little power pack wheel thing that you can see in this picture that's fitting between and underneath the manual wheelchair. So it basically clips onto the crossbar in the back of your chair. And again, I describe it to patients as a power pack. It gives you that extra little oomph when you're going up hills, when you're traveling long distances. It's really meant for that community distance mobility for people that are primarily using wheelchairs for community mobility. So the newest revision that came out, I really like it. It's all managed through a Bluetooth wristband, and so it looks almost identical to a Fitbit, and it's all managed through a series of taps. So you do a certain number of taps and a certain type of tap to get it started, then you tap it to lock it in the speed that you want, and it maintains that speed until you tap out of it. And so it's all based on the taps, and the people that I've had that have gotten the newest version of it, while there's certainly a learning curve because it's different than the previous version, they really like some of the modifications that have been added on to it. And so these are really the options for manual chairs. Like I talked about, there's lots of options for customization and things to do with that. So in terms of power wheelchairs and power mobility, I'm not often recommending these for folks with spina bifida, simply because the vast majority of my patients have really strong arms, and I look at power wheelchairs for those that may have weakness in their arms or having difficulties propelling that manual wheelchair, which is a very, very small proportion of the folks that I see in clinic. So these would be really more applicable to those who are having the higher thoracic lesions that are having their arms affected, or even individuals that may have a syrinx that's causing them to have weakness in their arms and have difficulties propelling a manual wheelchair. If my patients are able to propel a manual wheelchair, I'm going to look more towards something like a smart drive to give them that extra oomph, because I do think it's really important from an exercise standpoint that we kind of meet folks in the middle and get them some activity, and that really can be provided by a manual wheelchair when a power wheelchair doesn't do that. But in general, power wheelchairs are fantastic. They have lots of awesome bells and whistles. Again, the vast majority of things that you see on these power wheelchairs are customizable. You can choose different headrests, you can do different backrests, both in shape. There's options to customize your backrest and mold it to the individual. So for those with things like scoliosis or different other back deformities, we can accommodate those, and so folks are a little bit more comfortable. Same thing goes with seat cushions. There's lots of different materials that seat cushions are made out of. You can also custom mold a seat cushion for those that may have hip dislocations or dysplastic hips and may not sit well on an even surface. So in terms of looking at your wheelchair seating, I've sort of started to allude to this, but we're going to go into a little bit more in depth. The things that I always think about as a rehab physician and try to talk to all my patients about are on this page. So I want folks to look at a high quality cushion. Now what that means for each individual is different. Some people have just specific preferences. There's lots of different materials that you can make wheelchair cushions out of. The same goes for both manual wheelchairs and power wheelchairs. They can be made out of foam. Some are made out of air. There's a great one that a lot of people really like called a Roho. That's the name brand of it. And then there's also cushions that are either fully gel or just have a gel overlay. Each of these has pluses and minuses in terms of comfort for individuals, how much give they provide, how much support they provide, whether they're, breathable versus a little bit hotter. And really, this is a lot of times a personal preference. For full-time wheelchair users that are using their wheelchair, the vast majority of the day and are sitting in their wheelchair the vast majority of the day, your cushion should really be replaced every 1 to 2 years. They're not meant to last much longer than that. I think most people probably don't replace them every 1 to 2 years, but if you're a full-time wheelchair user, that's how frequently you should be doing that. Other things that I may recommend are related to cushions or pressure mapping. So in this, you basically just sit on a piece of, it usually is just an overlay. It's a flexible overlay that folks sit on, and it gives you a sense of when you sit on a flat surface or when you sit on a particular cushion, where are the pressure points that you're sitting on, whether that's the left side, the right side, over your tailbone, and it really gives both therapists and the vendors an idea of, is this an appropriate cushion for you? So the everyday person that's only using their wheelchair for community distances, they're not using them full term, they've never had skin issues, they don't necessarily need to have pressure mapping. But times that I'm recommending it typically are for people that don't sit well on a flat surface or have had pressure issues in the past that we think are related to their wheelchair. I'm always going to recommend that they get pressure mapping when they're getting their new chair. Some other things that you can add on and look into when you're doing your wheelchairs, like I talked about, are the trunk supports. Those can be things like you can actually get a back brace that helps you, that you wear, that you can help sit you up a little bit more upright. So that's called a TLSO. Things that you can add on to your wheelchairs are lateral support. So in that bottom right picture, the things that are kind of added onto the trunk that would encompass your trunk and keep you more upright, those are called lateral supports. And then hip adductor pads are another one that I often recommend for those individuals who sit more open-legged. These are going to keep your hips and your legs more aligned in midline and keep you more flexible long-term and in a better position long-term. like I alluded to, custom seating is an option. You can get that done for your back, your main cushion, or both. And the biggest thing we're trying to prevent as well as accommodate are those orthopedic deformities. So I truly think that if you are a full-time wheelchair user and you're vigilant about your seating and positioning and getting into a good position, we can try to avoid things like development of scoliosis and hip dislocations. We may not be able to avoid them in their entirety, but we can hopefully prevent the progression of them. With that being said, we're also accommodating those. So often kids are still developing scoliosis, they're still developing hip dislocations, and it has a lot to do with their level of lesion, and kids can't control that. And so in those instances, we're looking at unique ways to accommodate a significant scoliotic curve or one hip that's out, and make those individuals comfortable and able to propel their wheelchair and be functional and have an independent form of mobility. So with that, Jeremy, can you post poll question number 3?
I sure can. And the question is going to be, at what age did you or your child get their first wheelchair? We don't include Zip-Zacs or the Scoots in this. 3 years or younger, 4 to 7, 8 to 11, 12 to 15, or 16 or older. And wow. Okay, well, we already have 100% of the response, and it's evenly split. It is
okay.
8 to 11 has 50%, and 16 or older has 50%. So we'll go ahead and close that now. And
cool. And that is kind of what I sort of expected based on my other poll questions in terms of what braces folks are wearing, and that more that community distance ambulation. That's often when we're starting to see people be interested in getting that first wheelchair, is really when they're starting to do activities outside of the house. They're starting to be want more independent for longer distances, and they're just not able to keep up with the demands that walking entail. And so that actually is pretty similar for the group that I think we have watching live right now. So the next thing I wanted to touch about, because I think this is really near and dear to my heart right now, and I think a lot of people are going through a lot of frustrations in getting new chairs. This has always been a source of frustration, I think, for the average rehab physician in terms of getting insurance to pay for your mobility devices. And so the thing I've seen over the last 5 years is that there is just a very, very wide variety in coverage based on your individual healthcare plans. And to go along with coverage, I think there's a wide variety in how easily or how hard it is to get your wheelchair. And so typically I would say power wheelchairs in general are a little bit harder to get covered, but that's not typical across the board depending on your insurance company. So these are just some general rules of thumb when you're thinking about getting a wheelchair, kind of planning for that next wheelchair. So most insurance companies will only cover a wheelchair every 5 years, a new one. This doesn't necessarily matter whether you're little, whether you're an adult, but typically it's pretty much across the board. 5 years is kind of that cutoff. Now, with that being said, some insurances have clauses in them that if you have what they call a significant change in status, they will allow you to get a new chair. Now, they don't often define what a significant change in status is, and that's where it gets a little muddy. So what I always tell folks is, while it's great if you have that clause in there, you really want to make sure that you're planning for that 5-year period. And so not only does that include function of the chair and what the individual may be needing it for, but also accommodating for growth. So when you look at the chair, if you're getting your first chair, let's say at age 5 to 7, you're going to need to continue to have that chair until you're about 10 to 12. And so the needs of a 5 to 7-year-old may not necessarily be the same needs as a 10 to 12-year-old. And every 5 years after that, a school-age kid's needs are not going to be the same needs as a high school-age child or a high school adolescent or even college or adult. And so really when you're picking out that chair and thinking about what you need it for and what you're getting on it, you want to think about the next 5 years. The other big part of my job as a physiatrist, as well as the therapist and the vendor's jobs that we have to do to the insurance company, is that we have to prove that it's medically necessary for the individual to have a wheelchair. Now, this often is different depending on how each individual healthcare plan is written. Some very clearly have provisions for what is medically necessary and what is not. But I think the biggest thing I can convey to you as either parents of children with spina bifida or individuals with spina bifida is that to provide the best chance of getting your wheelchair covered from a medical necessity standpoint, it really benefits you if you're working with a therapist that knows how to order wheelchairs, has done it before in the past, is comfortable with writing the letters and the documentation that need to be submitted, and also if you're working with a rehab physician or a physiatrist. I think if you do those two things, and you work with somebody who's well versed in getting wheelchairs, you're going to have the most chance for success. There's a lot of things that are just nuances in how we write things that someone who may not do as many or order as many chairs may not know how to write it that certain way because it's not necessarily intuitive. The other things in terms of just planning ahead. So right now, on the average for a chair that is not, I would say the insurance company, quickly approves it and it goes through the process fairly smoothly, it's taking about 3 to 6 months to go from the point that the documentation gets submitted to the insurance company to the time that you have that chair in your possession. And so just think about that when you're planning for vacations, when you're planning for big transitions, we're going to middle school, we're going to high school, we're going to college. That's the average time frame that it's taking these days. I will say that I've had some manual chairs approved quicker than that, and I've had some recently that have taken longer than 6 months. So it's really, really hard to predict, and I think a lot of that just has to do with those variations in healthcare plans and whether or not you get a denial and how many denials we have to go through before we get the chair approved. And then conversely, if you're looking at power chairs, 6 to 12 months for power chairs, they're just a little bit longer. And so like I talked about a little bit earlier, working with that PT or OT, that therapist who is well-versed in wheelchair recommendations, as well as working with a rehab physician really helps you move through this process as seamlessly as possible. It's not always seamless. Even those people that keep in constant contact with their therapist, their vendor, and their rehab physician still can go through multiple denial processes. But the other thing to keep in mind too is most insurance companies are now requiring that if a physician signs off on your wheelchair, you have to be seen within the last typically 6 months. Occasionally they'll allow up to 12. And so just in general, like I talked about with braces, keeping in close contact with your rehab physician and not allowing time to lapse, more than a year often speeds up the process. So the other thing I wanted to talk about that kind of dovetails off of wheelchairs but aren't exactly the same thing are things that fall into the category of standers. And so many of you or your children have maybe used standers in the past, maybe not. They come in two different styles. So in general, you can either have a static stander or a mobile stander. So that's the ones with wheels are the mobile standers. They actually function a lot like an upright wheelchair. Kids and adults can push them. They can get around the house in them, but they're in a standing position. And so the reasons I recommend standers are basically two big reasons. So they help get you some gravity going through your bones for kids that aren't necessarily doing a lot of walking and having that upright weight through their bones, and that's going to help a lot with maintaining their bone health. For kids who walk late or don't walk a lot, they're at high risk for osteoporosis just because of how our bones develop and how they grow as we mature. And so getting folks up in a stander to get some of that weight bearing is really helpful for bone health overall. The other big part that I think is really helpful for standers is that it helps maintain the range of motion at your hips, knees, and ankles. And so as you can see, kids will stand upright in these standers, and they're really getting a great stretch at those three joints when they're upright. And so for folks, I always tell my patients and my families this, for folks that are busy and it's really hard to get in your stretches and to work those into your daily basis, a stander can be a really nice thing to be able to decrease some of those stretches that you need to do on a daily basis. So a lot of the standers have trays. You can do your homework at them, you can watch TV in them, and you can kind of kill two birds with one stone, so to speak. So I think they're really a nice option, especially for the busy family, but they have lots of benefits in addition to that. So Optimally, the goal would be to get the individual in a standing position for 6 to 7 hours a week. That's been shown to kind of hit the sweet spot in terms of bone health and range of motion. Your body doesn't really care what 6 to 7 hours looks like. That could be really short 15-minute bursts to total that. It could be if you really wanted to stand for 6 to 7 hours in one swoop on one day of the week, you could do that as well. But in general, that goal of 6 to 7 hours a week. The one thing I'll say about insurance in terms of standers, they are often not paying for the mobile standers. They look at it as a luxury item. Mobile standers are more expensive than static standers. And, in general, for the purposes we're recommending a stander, they don't look at that mobile component as a medical necessity. And so if you're trying to get a mobile stander, the biggest thing I can recommend is to make sure that your therapist or your vendor isn't coding it with your insurance as a piece of mobility equipment. I've had a couple instances in younger kids where that's happened when I recommended a stander, typically sometime around the age of 1.5 to 2, when kids aren't meeting that walking milestone, and we don't think they're gonna meet it for a while. We'll start talking about standers, but they accidentally or purposely get coded as a mobility piece of equipment, and then a year later when they're outgrowing their typical kid stroller and we're looking at things like wheelchairs to be able to get out and about in the community, we learn that they use their mobility equipment funding on the mobile stander. And so I just caution everybody out there about that if you're wanting to see if you can get a mobile stander pushed through insurance. So I believe this is our last poll question.
It is, and the question is, do you or your child use a stander on a regular basis? And the options are yes, a static one, yes, a mobile one, or no, I don't use them. So we'll launch that now.
And I bet I can guess where this is going based on the age that you all got wheelchairs, but we'll see how this ends up turning out.
And we have 100% in, and everybody says no, they don't use them.
No. It doesn't surprise me. So I'm assuming that folks on the live version of this tonight are probably a little bit lower level spina bifida. Without asking, I have no way of knowing. But typically standers, if we're using them for more of those higher level lesions that don't have the ability to independently walk. So in general, just to kind of summarize, because we're running out of time, and I know everybody's busy and needs to get back to life, but some take-home points if you're taking anything from this today. So just know braces are extremely important for all ages of folks with spina bifida for the two reasons we talked about, both helping with and maintaining function, as well as the one that's near and dear to my heart, maintaining foot position and hopefully helping to prevent you from needing surgery down the road. We're always doing bracing recommendations that are customized to the individual. No two kids with spina bifida walk exactly alike, and so I'm often looking at ways to tweak things that make things just a little bit better for the individual. There's lots of different mobility devices that exist, and overall you just want to make sure that you're customizing those to your needs, thinking ahead about what you need that piece of equipment for and conveying those needs to both your therapist, your rehab physician, and your vendor. Nowadays, you always want to try to plan ahead whenever possible. I know that that's not always possible. Sometimes your wheelchair just decides to tip over the breaking point and you're not expecting it. But really, if you're getting to the end of that 5 years and you think you may be interested in a new wheelchair, if things are not, your wheelchair's not as great as it once was, think about that a little bit ahead of time and bring that up with your rehab physician when you see them. And then, again, just keeping regular appointments with spina bifida team and specifically that rehab physician. I think that's the biggest, frustration I've seen with families nowadays is, for whatever reason, they missed their appointment, things got busy, and then they need a piece of equipment, they need braces, and it's out of that 6 to 12 month time frame from the time they saw their physician. And so then we're trying to kind of fit them in when, it's hard to find appointments that work on both sides. And so as much as you can try to keep those regular appointments, I think that ends up helping you in the long run. And I think only time's going to tell in terms of what insurance limitations we're going to start facing. And we're going to continue to face. We've faced them for a long time and they always are changing. And so we're just going to deal with them as they come. So there's some references for you. And then here's an email address that will link you to the rehab physicians at Cincinnati Children's, so myself as well as Dr. McMahon. This is probably the best way to get a hold of us, simply because it filters through our nurses, and they're able to remind us to respond to our emails if we happen to be at a busy time on service or various other commitments. And so if you have any questions before we wrap up over the next few minutes, if you want to type them into the chat box or the question box, I'm more than happy to answer whatever questions you may have. But otherwise, feel free to email any other specific questions that you don't want to ask today.
All right. Thank you, Doctor. And we do have a few that are here in front of us, so we'll go ahead and answer those. And again, as a reminder, you can type those into the questions panel on the application. So the first question to come in, or to give you, in your opinion, will the exoskeleton ever be available for everyday use? And are they even a relevant solution for those with spina bifida?
Yeah, so two parts of that question. I think relevance to spina bifida, I think it's going to depend a little bit on lesion level. I think certainly with what I know of exoskeletons and how they're helping those with the spinal cord injury population specifically, I think those with thoracic level lesions and even some of the upper lumbar lesions, as long as their range of motion is pretty good, I think those would potentially be good options. Now, the other part of that is, will they ever be available to the general person with spina bifida via funding routes like insurance or something like that? I think we are really years down the road from that happening. And to be honest, with the price of what an exoskeleton I've heard costs, unless it comes significantly down, I suspect that it's going to be really, really difficult to convince private or even Medicaid insurances to pay for pieces of equipment like that, when there's really other options in terms of standing and mobility. But we'll see how it goes. I think they're really awesome pieces of equipment, and I can't wait to see, as they develop and hopefully the cost comes down. Maybe in 10, 15 years, we're going to have a lot more of those being used.
Okay, is there a problem using a swing-through gait rather than a reciprocal gait when using loft-strand crutches? Someone says, my child prefers the swing-through because it gets her there faster.
Yeah. So I think overall, absolutely, kids are going to do what gets them from point A to point B as fast as they can, especially when they're younger. They don't care what their gait looks like. They want to do things quick. They want to keep up with their friends. I think the biggest thing for me is just making sure that I'm maintaining joint integrity, so the health of the hips, the knees, the ankles. Our bodies aren't made to do a swing through gait. That's not how we were intended to walk. And so the long-term ramifications of somebody who uses nothing but a swing through gait, while I don't think there's any research that I know of that is out there, I worry a little bit about the health of their joints if they're using nothing like that, but that type of gait. And so I'm really going to try to promote more of a step through gait and a typical gait pattern if you're using loft strands. But I think, if little kids are wanting to play around on their crutches and it's getting them from point A to point B for very, very short distances, it's probably okay.
Okay, a couple of questions regarding the drive technology. We haven't heard too much about the Firefly, which is the battery-powered device that attaches to the front of a manual wheelchair for community use. Have they not been as successful for getting around as a smart drive?
Yes. So what I have heard from our therapists who have tried out the Firefly Edition option is that they're not as stable. They are tending to break a little bit more easily. I don't know if it's the quality, if it's just it's a newer model, and when we have more modifications to the different versions of that'll get better. But what I've heard, that's what I've heard from the take home from the therapists that I work with that are doing a lot of the wheelchair evaluations. So they're not tending to recommend adding those on because they're just not as durable as say the Smart Drive.
Okay, and how are the eMotion wheels powered? Do you have to plug them in overnight, and what happens when they lose power while you're out in the community?
So that is definitely a downfall for the eMotion wheels. So they do need to be plugged in. They're a rechargeable battery pack. I don't know what type of battery or anything like that, but they're basically rechargeable. The newest version, I'm not sure how long the charge lasts, to be completely honest. That's something one of my therapists would probably know off the top of their head, in terms of the distance they'll go without them. But if they lose power in the community, it will basically revert your wheelchair back to a manual wheelchair, but the caveat being now your wheelchair weighs a lot more than it did before you added the eMotion wheels. So you're getting that added weight, but you just basically revert back to a manual wheelchair. So it's certainly not optimal, and probably one of the other downfalls that I didn't mention for the eMotion wheels.
Okay, and the final question we have tonight, or rather for this webinar, what are the most common stretches for people with spina bifida to avoid contractures and deformities, and how often should they be done?
Oh, good question. Good question. So typically the main joints that I recommend stretching are all of those that are going to help with your gait. So your hips, your knees, and your ankles. I would say in folks with spina bifida, typically your hips and your knees are going to be the ones that I'm recommending more. And the reason behind that is I know that, and I see it on a daily basis, kids that have a little bit more of that mid-lumbar to high lumbar region, if they have more contractures and they start developing contractures of their hips and their knees, compounded with the weakness that they have, they tend to start losing their ability to ambulate, or it just becomes much more cumbersome and much more difficult. So if I can help those individuals maintain their hip range and their knee range, they tend to do better with that. So I actually love what's called for the hips, I actually love what's called prone lying. So if you lay flat on your stomach on a relatively hard surface, and just stretch out those front of those hips, you'll feel a little kind of stretch across the front of your hips. You don't want to necessarily be pushing down on their bottom or just, cranking on them from that standpoint. But typically, if you just lay in a pretty neutral midline position with your legs straight behind you on your belly, that'll give enough of a good stretch for those with hip flexor tightness to kind of combat that. There's also some other ones that probably should be instructed in terms of appropriate technique from a physical therapist, but that's a really easy one to do without much, education and specific training. The other couple ones that I like for the knees, one of the main ones is something called long leg sitting. And so what tends to happen in kids with spina bifida is they develop contractures in their knees, or they're a little bit more bent than straight. And so if you sit up with your back against the wall and stick your legs out straight in front of you, just as straight as they'll go. A lot of times they won't go fully straight, but if you stick them out straight in front of you and kind of keep them in a midline position, you'll feel a nice little stretch on the back of your knees and the back of your thighs. And that'll do a really nice job of stretching your hamstrings and helping to prevent those knee flexion contractures. The ankles, while I want them to maintain flexibility, they're a bit more difficult to predict because that tends to be a joint in individuals with spina bifida that isn't consistently tight in one direction or another. So some kids tend to be a little more tight in a pointed down fashion. Some kids tend to be a little more tight in a pointed up fashion. So those are typically stretches that I try to individualize to the specific foot, and often have folks with spina bifida work with a therapist on, just to make sure you're doing them right, because they're just not as easy to talk about over a webinar.
All right, and with there being no further questions, I will turn it over to Diane for the wrap-up.
Thank you, Dr. Bolger, and thanks to everyone for attending today's webinar, Understanding Orthopedic Options. If you have any other questions, please email either Dr. Bolger or Dr. McMahon at the email that she provided, or me at dburns@sbccincy.org, and we'll make sure to get those questions answered for you. On behalf of the Spina Bifida Coalition of Cincinnati, Cincinnati Children's Hospital Medical Center, our presenters, and the Hatton Foundation, we thank you for joining us. Now go create your future.